Welcome everybody to the CBP Nonprofit Research Video Review. This week we're going to be going through a very nice case report. This case report is a very interesting application of CBP techniques in a chronic whiplash associated disorders case. And you'll see the benefits of corrective care for this patient once we go through this particular report. As you know, if you've been watching these videos, each week I pick a new CBP nonprofit research publication to go through. And we have many to go through. In fact, the goal is to go through all 156 of our research publications in a video review. So we'll probably be doing this for roughly 3 years, if not a little bit longer, because if you're paying attention, once in a while I skip a week just due to my time constraints, etc. I'm not exactly going in order of year and date of our publications, but I am trying to have a consistent theme of going through relevant cases as we build, or relevant reports as we build. For example, what we've done before we went through this case report is we've gone through the reliability of CBP X-ray line drawing procedures for the lateral cervical view. We've also gone through our CBP ideal and average spine alignment values for the lateral cervical curve. And so that brings us to case application. Now that we have established reliability of our methods and we have validity of our cervical spine model for the lordotic cervical curve, we can now look at abnormalities in a much clearer perspective, and then we can see what happens when we apply CBP corrective care procedures to cases that are indeed abnormal. Now, understand that this is a case report. However, well done case reports, especially chronic cases that have failed standard and detailed traditional types of care, when we do a unique type of care, if we see a result, we can look at this and we can go, wow, this is likely going to be consistent with randomized trials that are done on the exact same population. And in fact, that's known to be true. If you look at case studies in the literature and level 3 reports, what you'll find out is well done case reports and level 3 reports, which is cohort studies. What you'll find out is if they're done well, they are actually consistent with randomized trials on the same topic. So while this is only one case and we need to build on that platform, it is a very well done case report. This case was number one, treated by and spearheaded by my good friend and CBP instructor, Dr. Joe Ferrantelli. This is when he was in active practice down in Newport Richey, Florida. And if you know Joe, Joe always had a passion for corrective care and for treating whiplash injured subjects, okay? So on this particular paper, we have Dr. Joe Ferrantelli, we have myself, Deed Harrison, we have my late father, Donald Harrison, and then we have one of the treating MDs that Dr. Joe was collaborating with at the time, Dennis Stewart from the area. This was published in JMPT, the Journal of Manipulative and Physiological Therapeutics, in 2005. It is volume 28. It is page 205E through 205-8, and that's online. Okay, so online in the Journal of Manipulative and Physiological Therapeutics. Okay, so background. This is a whiplash injured case. This individual was on the police enforcement law. He was a law enforcement officer in the police department. He actually was treated traditionally with previously, right after the injury, with approximately 18 visits of standard diversified style chiropractic. Also, some physiological therapeutics were used, PT methodology. In addition, the patient received physical functional rehabilitation for strength and conditioning of the cervical spine, as well as pain management medication. The patient failed these things and turned into a chronic case. The patient will see disc herniations, and they're mild disc herniations at more than one level, multiple level. Also a chip fracture of the lower cervical spine, anterior superior vertebral body. So we have MRI, we have a mild fracture, and we have a patient that's unresponsive to what's called traditional or traditional conservative care for whiplash injured subjects. This patient then turned into a chronic case, still suffering, went to an MD. The MD gave the patient a whole body permanent impairment rating of 33% due to the symptoms and due to the side effects from the motor vehicle collision. Okay, these we'll see what these all entailed, but there was some grip strength weakness, there was abnormalities in the C5, C6 dermatome, as well as chronic pain, decreased range of motion, etc. So the surgeon that gave him the whole body impairment rating then said, you know what, you failed all these things, chiropractic, PT, pain management, now we must do a discectomy and fusion. Well, fortunately, this patient happened to be colleagues with a family member and other patients that were seeing Dr. Joe Ferrantelli. And they recommended that he go to Dr. Joe Ferrantelli's corrective care facility. And Joe took a look at him and said, you know what? Your x-ray nearly looks identical to the one immediately after the crash. So let me back up. This lateral cervical image was taken at the initial chiropractor's facility, and you can see a large anterior head translation, and you can see straightening and a lower cervical kyphosis. And then here's the MRI, and this MRI was taken weight bearing, although we flipped it to be consistent with the perspective of the x-ray. So it appears to be upright, but it's not. So the person is supine on their back. You can see when they're on their back, the anterior head translation is improved. And what you can notice is the cervical disc herniations, the mild ones down in the mid and lower cervical region. Now, they're not making direct contact with the spinal cord, but you can see the displacement or the effacement of the thecal sac in through here. So we know that when this person's upright, it's going to be much more severe. We're going to see that disc in contact, you know, with the spinal cord, not the spinal cord, but the dura, and it's going to be likely putting direct shear load acting on that cord interface between the disc and the thecal sac. So when he goes to see Joe, this is after all this care, okay? And this is after the permanent impairment rating. He comes to Joe, 33% whole body impairment rating. Neck disability index is 46%. That's severe disability on the neck disability index. And at the time of the visit, he's a 5 out of 10. That's considered moderate chronic neck pain. So his chief complaints are neck pain, headaches, scapular pain, right arm pain into the C5, C6 dermatome, and also abnormality in the reflex and the sensory distribution there at the C5, C6 dermatome. Also, reduced cervical range of motion using inclinometry. There's the C5 chip fracture, and then the primary herniation was C5, C6, but you noticed on the MRI there was more than one level. Now, why is this case still chronic? Why is he still suffering? Okay, well, you could say, oh, he's malingering, it's psychosocial after the car accident, he's trying to get a settlement. You know what? That's all bullshit. Sorry for that, but I just get so irritated with that. You're going to assume that a police officer that's in his prime, that loves his job, that is willing to go through all this care, you're going to assume that he's malingering? Come on, give me a break. Psychosocial problems? I don't think so. You know what? There's reality when we look at these cases, and then there's made-up perceptions, okay? The psychosocial problems are coming from the fact that he can't perform his activities of daily living and his job duties. That's why he's got psychosocial problems, not the other way around. So we look at this case, we go, this guy's head so far forward. This is part of the problem. Let's compare it to studies in the literature that have already been done on subjects that have whiplash compared to a control population. And what you'll find out is the ones in a motor vehicle collision, these are the ones that have much more significant abnormalities structurally and functionally. Psychosocially, they're not making up their anterior head translation. So let's look at this paper from Advances in Physiotherapy 2005. What this did is this took a group of subacute and chronic whiplash-associated disorder sufferers, compared them to a control group, and they looked at, let's identify what the magnitude of the anterior head translation is. Now this was done seated, and it was using a simple angle to determine how far the ear is in front of the upper thoracic and lower cervical spinous process. Now the greater the angle, the further the head is forward. And you'll notice here's the whiplash-associated disordered subjects. This is the mean and standard deviation bars. And then here's the control subjects. So you can see that we have a greater magnitude of anterior head translation, and also it's statistically significant. It's not just a greater magnitude, it actually did reach statistical significance if you read the paper. To me, this is likely an explanation for why this person still hurts. The head is way forward. It's putting load on the cervical spine tissues. It's putting load on the disc, load on the facet. That disc is already injured. You increase the load on it, it's going to flare it up even more. It's going to stimulate and trigger excitatory, chemicals in the disc and around the tissues. We're going to get substance P. We're going to get matrix metalloproteinases. They're going to build up. These increase pain, they lower pain pressure thresholds, so the person is more susceptible to pain from mild pressures, and it also accelerates degradation of the tissue. So you get a catabolic activity in the disc and the tissues instead of an anabolic activity. That's what matrix metalloproteinases do, and that's also what the long-term effects of substance P is. So the other issue is this person's got an abnormal cervical curve. They've got a complete straightening, if not a mild kyphosis, in that mid and lower cervical spine. What does that do? Well, that's also going to increase the load on the tissues, and it's also going to put load on the spinal cord. Okay, so we're going to see two things from this kyphotic neck. It's going to increase the load on the disc and the vertebral body, and we know that through past research, and maybe we'll go through those projects in a future video. In fact, we will. And we're also going to load the spinal cord. Now, when you do that, we're going to have sequela from that. What is that? Well, we're going to have pain, arm pain. We're going to have numbness and tingling, grip strength weakness, sensory and motor disturbances. This is what this guy has, right? This is a problem for a law enforcement officer that can't grip his firearm properly, right? Okay, it's not psychosocial. It's coming from a biomechanical insult to the neck, okay? So past studies, this one, for example, 2001 Journal of Spinal Disorders, Kai et al. What they did is they looked at prospectively over 100 subjects that were involved in a motor vehicle collision, specifically a rear end impact collision. And what they did is they looked at the ones that were suffering, worse than the other subjects. By worse, in this case, neurogenic thoracic outlet symptoms. This is arm dysfunction coming all the way down from compression on the brachial plexus, right? Well, we also know it's not just compression on the brachial plexus in here from the thoracic outlet, it's also internally inside the cervical spine. You've got an abnormal curve, it's putting stress and strain on the spinal cord and nerve roots. That's the initial problem. Then you add compression from the scalene muscles, etc., and a little vascular disturbance in through here. Now we've got thoracic outlet symptoms. Well, what they identified is the subjects with neurogenic thoracic outlet symptoms in this population of whiplash injured subjects, 44% of them had kyphotic configurations of the neck. That's huge. 44%, that's almost half. You look at the asymptomatic population, that is absolutely not even close to that. Asymptomatic people don't walk around with a kyphotic neck on average. Now, once in a while you see it, but you're not going to see 44% of them. So you get the idea, right? This is a big, big deal. This is a prospective study. It also did a year-long follow-up, and they found out at the year-long follow-up, one of the risk factors for continued problems, that means continued neurogenic thoracic outlet symptoms, is having a kyphotic neck. So this is a prospective longitudinal study, very important. Also, the disc herniation issue. This particular project, very nice, came out in 2002 out of emergency radiology. Okay, these guys, what they did is they looked at subacute and chronic whiplash injured subjects rear end collision. Okay, they have 100 of them. Subacute means at least 12 weeks of symptoms or greater. Okay, then they then matched them to a control population of 100 subjects that did not have a history of rear end collision or whiplash injuries. What they identified on MRI is huge differences in the amount of, or the frequency of occurrence of two things. Number one, disc herniations, right? If you look, how many of these subjects had disc herniations in the whiplash injured subjects? Look at this. Disc herniations, 28% of this rear end collision population. 28%, that's 28 out of 100. Disc herniations in the asymptomatic, 2%. You're 14 times more likely to have a disc herniation in a motor vehicle collision. Do you think the cop is malingering that? You think he's making up a disc herniation? It's on the MRI. And it's linked statistically to the crash mechanism of injury, right? Then you look at it, he's got a chip fracture from it as well, too. So, geez, that was a pretty damn good acceleration impact and high forces exposed to the cervical spine tissues, right? The other thing is, look at the frequency of loss of the cervical curve. Asymptomatic, 4%. Subacute chronic whiplash subjects, 98% of them have a loss of the cervical curve. And this is on MRI, non-weight bearing MRI. When you stand them up, you're going to see kyphotic configurations, etc. Look at this, 98 out of 100 have a loss of the cervical curve. Now you can't tell me that's not a relevant issue. So to me, I look at this data was pre-existing to this particular paper that we published in JMPT. So we have evidence that says this is likely why this patient is still suffering. Nobody bothered to take into consideration the guy had 3 inches of anterior head translation and a severely straightened and kyphotic cervical curve. To us, this is why the guy's still suffering. So here's what Joe did. He said, look, here's what has not been done with this patient. Let's take his posture, forward head posture, rounding protraction of the shoulder girdle area, that means the scapula, and internal rotation of the glenohumeral joint, and let's start doing mirror image, meaning opposite positional procedures with him. This is what my late father developed for CBP technique, or chiropractic biophysics technique. My dad said, you know what? Let's just do the opposite and apply forces to it in controlled manners. So we lay the person supine on a drop table. You'll notice the thoracic piece is elevated. What that'll allow us to do is lower the head below the thoracic spine. You'll notice that the shoulder girdle is going into retraction. So we're pulling the shoulder blades back, opening up the chest area, stretching the pecs, and then we're externally rotating the glenohumeral joint. Then Joe is in a very controlled manner. He's taking the skull and translating it backwards into posterior head translation, as well as creating cervical extension. Now, at first, we're careful with the amount of translation and extension we do. However, over time, you can get people into these positions. So what's shown is not the first visit with people. So you've got to realize this. If you're brand new to CBP technique, or if you're a patient that's out there, you got to realize we're going to wean you into these procedures, right? They didn't build Rome in a day, and we can't change these postures in a day. We're going to slowly work you into it. We use drop table techniques and instrument adjusting techniques. This is called a drop table maneuver. It's called a drop table because this headpiece will cock about 1/4 of an inch up in the air, and when we push pressure down on it, it drops that 1/4 of an inch. Now that drop creates an input into your system neurologically that helps us change posture in the cerebellum and, you know, from a neurological point of view. We're basically resetting postural balance with this. Okay, if you want a background on that, maybe I'll give you a review of neurological theories explaining why these techniques are known to change posture. It's called, in graduate level mathematics, it's called Renee Tom's catastrophe theory. So we can explain how these positions and procedures in this drop with the drop table, if done right, will trigger a reset of your body's sense of balance. Okay, anyway, this is what was done. 3 to 5 times per week. Every day is recommended, minimum of 3 times per week. Also, we're going to be doing extension compression traction. Now, we went through our extension compression traction clinical trial, and we know that this is an effective way to rehabilitate anterior head translation and loss of the cervical lordotic curvature. You cannot start in this position day one. So you start gently hanging the head back, and over consecutive days you work the person into more and more translation, more and more extension, and then we start to add force on the forehead application, or the forehead strap here, right? The forehead strap will pull back and down. Now, shown here is after the patient has built up tolerance for this. We're going to start with 1 to 3 minutes the first time, and then work our way to where we're doing 15 to 20 minutes per session in this compression extension traction. This is the exact mirror image traction that is recommended for this neck. It translates the thoracic spine forward, it extends the shoulder girdle and upper thoracic spine backwards, it retracts the shoulders, and it translates and compresses and extends the head. So this will improve the cervical curve. Also, mirror image exercises were done. Now, the picture doesn't show the exact position of the shoulders that's correct. However, what is shown, we translate the rib cage a bit forward, we translate the head backwards and extend over this fulcrum here, and then he's required to retract and externally rotate his shoulder and scapular area. Okay, when he does that, he's going to actively move as far as he can, hold the position with a mild at first, moving into a moderate or aggressive contraction. He's going to hold that for 5 to 10 seconds. He's going to repeat that 50 times per session once he's comfortable doing that. Now, the first time we do it, we might only be able to do 5 to 10 repetitions of this. However, we're going to work up to where we can do 5 sets of 10 or 50 repetitions at minimum in the office under supervision. Why under supervision? Well, notice what he's not doing in the photo. Well, either the photo was taken when he was just modeling for the photo and they forgot to do it, or maybe he actually forgot to do the shoulder component to this. Either way, this is why we do it supervised in the office, so we make sure it's done right. Now, today, we know that we should also use a fulcrum strap to exercise the cervical lordosis while we're doing translation and extension. The fulcrum allows that curve to experience an anterior shear load or a transverse load, so it'll force a better curve to come back in while we're doing this. This wasn't done in the paper. I'm showing you this today because this is what we would recommend in today's knowledge. 10 years later, we've figured out that, in addition to doing this full body exercise, we should also use a fulcrum type maneuver at the apex of that cervical curve. Since he's got so much head translation forward and loss of the lower cervical curve and middle, we'll put the force application down low and the arms go straight. If it was more of a mid and upper cervical curve, we would change the position to the mid and upper cervical spine, and then we would raise the arms up in the air. Okay, so again, this exerciser called the prolordotic exercise was not done. The one on the left was done with the patient. And you'll see, in the outcome, one of the results of perhaps not doing this fulcrum type of exercise. The first re-examination, so approximately 9 weeks of doing this. Okay, approximately 9 weeks later, we do a re-examination. What do we notice? A dramatic change in the posture of this person. The shoulder girdle's better, the head alignment is better, and we also repeat the x-ray, and we see a great change in the amount of anterior head translation. We see the start of a cervical curve forming. Now, he started at about 3 inches forward. This is approximately 25 to 30 millimeters forward. This is a huge correction. You'll notice that the lower cervical spine has actually moved backwards relative to the CBP idealized model line. Part of that is due to the type of traction that was used, the compression extension traction, and also perhaps the lack of the fulcrum on the exercise. However, this is a great change. Also at this re-exam, pain, disability, proper examination, and range of motion were done. I will show you those outcomes at the end. The person is now better, but they're not totally done. So what Dr. Joe Ferrantelli did is he recommended another program of corrective care. When you see staged improvement in somebody that was chronic, for a year this person was chronic and stable with, what would be called permanent impairment by the orthopedic surgeon, 33%. Now, 9 weeks later, it's not so permanent impairment. You're seeing improvement. So what do? You keep going because you have exam and documentation findings that say, hey, we are improving this person. They have not plateaued. We're continuing to make change, so let's keep going. So now we have a new alignment that we're starting with. This is where we want to change things up. This is where we're going to have to add a fulcrum to the mid and lower cervical spine so we get that area to bend properly, right? In essence, we want this lower cervical spine to move forward a bit and start to curve backwards. So what Joe did is he put this fulcrum or transverse load strap on the compression extension unit from Dr. Dwight DeGeorge in Saugus, Massachusetts. This is called the total target force unit. And this strap, you can control how much pressure is pulling forward in the neck, and you can control the location. So this is what Dr. Joe did. If we had had the prolordotic exercise band, it would have been a good idea to use this as well. So now the patient is going to continue with these procedures with a modification of what we're doing with the traction. Also, we're going to modify the adjustment. It's not shown, but what we would do is instead of putting the person on their back now, we can put the person face down, we can elevate the head up and extend, and we can contact with our hands this lower cervical spine and do a P to A toggle type of application, which will increase theoretically the curvature in the neck. Now we know that when we do that, that's not necessarily going to totally change the cervical curve, but we certainly believe it enhances it. It's logical to do it, even though doing that by itself is not necessarily going to make consistent changes, okay? We know that from our past study that we did. However, we think it's a good idea to do it anyway. Here's the range of motion evaluations. The patient was treated a total of 3.7 months, okay? And those treatments were 3 to 4 times per week, 3.7 months. First re-examination, this is the inclinometry. Negative RxH is extension. First re-examination, second re-examination, approximately 2 months later, third re-examination, approximately 4 months later, and then we have a long-term follow-up. That's another thing with this case. We have a long-term follow-up evaluation. Okay, not only do we show we improved him, but we show we maintained that improvement at long-term follow-up after care was terminated and the patient was put on supportive care. Look at the extension, 36 degrees, 51, 65. Long-term follow-up, we've lost a little bit of that. Flexion, 54, 54, 50, 68, and then back down to 57. Lateral flexion to the right. 30 degrees, 40 degrees, 55, lost a bit of that. Lateral flexion to the left. This one was more significantly impaired. 20 degrees to 30 to 58 to 42. Head rotation to the right, okay? 30, 60, 90, and 78. Head rotation to the left. 28, 45, 80, 89. Now look at this. You're seeing staged improvement in the range of motion. Yes, at long-term follow-up, approximately a year later, we're losing a little bit of that improvement in range of motion, but the most dramatic ones, lateral flexion to the left, head rotation to the right, and head rotation to the left are still dramatically improved, even with limited care over a year. However, this shows a couple things. Number one, staged improvement in the range of motion was identified as this person's spine was corrected. This is not a permanent loss of range of motion. It's permanent only because his posture was permanently impaired. There's a connection between abnormal alignment and abnormal movement. In mechanics, it's called structure determines function, right? It's obvious, it's common sense. I'm going to show you a study that confirms this. People, for some reason, they don't believe it. So you got to show them a research paper that shows, you know what? If you take people and you look at the magnitude of their head translation, and then you have them undergo range of motion maneuvers, and you quantify it with today's technology, what you'll find out is functional range of motion is dictated and determined to a great deal by the alignment in the sagittal plane of the person's head relative to their thorax. This particular paper came out in 2006 by Fernandez et al. In the journal Cephalgia. And what they were doing is comparing a chronic headache population to a normal population. Now keep in mind, our patient does have chronic headaches after a whiplash injury. So the Fernandez paper does apply to him in terms of a pain issue as well. However, the biggest issue is, what did the Fernandez group find? Well, they found out when they looked at range of motion that there's a linear correlation between the magnitude of forward head translation and the magnitude of reduction of your cervical range of motion in lateral flexion and y-axis rotation. This is exactly what our patient has. It's linear. Okay, so you look at this. Finding number 2 from Fernandez. Linear correlation between forward head posture and range of motion. Also, they identified as forward head posture increased in this patient population compared to the controls, the headache frequency increased. So there's a linear increase in headache frequency with a linear increase in head translation. No wonder the guy didn't have any improvement from traditional care, because the traditional care didn't do anything to change his alignment. It's just, to me it's like obvious, common sense. Here's the 3.7 month follow-up. This is the second evaluation that Dr. Joe Ferrantilli did with radiographs looking at the outcome. So this is the initial compared to the end of corrective care 3.7 months later. Look at the remarkable change in body postural alignment as well as radiographic alignment. The head translation is entirely improved. The cervical curve is within normal limits. Yes, there's still a C5 chip fracture, but look at what happened to the permanent impairment. 33% down to a 4%. Now the important thing is, this patient was sent back to the same orthopedic surgeon that did the initial permanent impairment rating. So the same surgeon now looked at him and goes, whoa, it's not permanent anymore, it's down to 4%. What did you do? Well, you know what? What he did was he got his neck fixed, like should have been done the first time. Look at the NDI. It was 46%, severe disability, down to 0. The NRS, 0 out of 10. Range of motion is normal at the final or the end corrective care reexamination, not the long-term follow-up. Okay? This case is a very nice case. It demonstrates clearly that in this case, the correction of the sagittal plane abnormality of the cervical spine and the posture was what was exactly causing his improvements. Okay? We would suggest to you that his abnormality is the reason he was continuing to have these chronic pain and impairments. We then did CBP corrective care that was directly related, staged over time, to his improvements in his pain, his disability, and his range of motion. It's directly correlated. This was a stable, chronic, abnormal patient. Chronic defined by non-responsive to traditional care and pain management. The orthopedic surgeon gave him a 33% whole body impairment rating. Surgery was recommended. After 3.7 months of corrective care, no longer was he suffering those same things. His pain and disability was actually 0. It was 0, right? NDI 0. Pain 0. Range of motion within normal limits, right? Goes back to the orthopedic surgeon. Well, you know what? You still have the disc herniation, you still have the fracture, so you still have a 4% whole body impairment, right? This case clearly shows what happens when you don't do corrective care versus what happens when you do corrective care. And there's a 1-year follow-up showing that the patient maintained those improvements in pain and disability, although mild reduction of the cervical range of motion was identified, specifically in flexion extension, right? Had he kept up more consistently with the maintenance care, likely that would have been improved too, right? So again, case report, but you know what? Well done case reports are consistent with randomized trials on this topic. So if you took a randomized trial, or you took 40 subjects that had the same condition this patient had, and you did a randomized trial where 20 of them, you just let them do standard care or no care, and 20 of them you do what we did here, you will see that the results will likely be the same as what this case report showed. So well done, Dr. Joe Ferrantelli. And you know what? There are so many patients. There's thousands and thousands of patients out there that are still suffering. They've been labeled malingerers. They've been labeled psychosocial problems, right? Still wanting to get some kind of money, still wanting to get settlement. Well, you know what? They've already settled their case. The insurance company already paid them. Now they've moved on from that, but they still have pain and disability. What do you do for those? Well, you know what? If you're one of those people out there and you're watching this video, find a CBP trained chiropractor. Go to cbppatient.com and look up a CBP trained chiropractor, and you'll find somebody there that can help you and get your spine corrected, right? And if you're a patient out there watching this video, sorry for swearing, but got pretty excited at the beginning of this. You know what? It's one of these things that I'm so frustrated that patients have to suffer when there's a logical answer for their problem. That's the purpose of me doing these videos, to try to get this out there, not just to the doctors, but you know what? Patients can get on here and look at these YouTube video research presentations by me as well. Again, I'm Dr. Dean Harrison. I'm president of Chiropractic Biophysics Technique. I'm president of Chiropractic Biophysics Nonprofit Research. And this is a formal research publication that was done in 2005 in the Journal of Manipulative and Physiological Therapeutics. If you like this type of work, please consider supporting us and helping us. We want to continue helping the public at large and improving the type of health care, conservative care, non-surgical that these patients get, right? If we can stop a certain percentage of patients from having surgery, then what a deal. We've saved certain people in many of their health disorders. We've prevented a cervical spine surgery that we know is beneficial for some people, but in the long run it may not be so fun when that surgery breaks down or your segments break down above and below that and you have to get a second and third surgery. So if we can prevent it, we've done a great service to humanity. We've also saved a lot of healthcare dollars and costs by this. So if this interests you, please continue to support our efforts through Chiropractic Biophysics Nonprofit. You can go online, support us directly on our website, or you can do it indirectly through Amazon Smile and just select Chiropractic Biophysics as your nonprofit charity. Hey, thank you for your time and attention. Till next time, I look forward to talking to you. Be safe.